Hello, my name is Gillian Newstead, and today we're going to talk about an interesting case regarding a misdiagnosis of a triple-negative breast cancer. We're going to be using QuantX software by Clarity for this case study. By way of disclosure, I am a medical consultant to Clarity Imaging, and I serve on the advisory board of Medscape. This is the QuantX indication for use. Please see risk information at the end of this video. So by way of background, a 62-year-old woman presented for routine mammography screening, and a small mass was found at 9 o'clock position, and I'm going to show you the images in just a minute. The small mass was also found on ultrasound, about 5 millimeters in size. It was an oval anechoic mass that was incorrectly diagnosed as a cyst. I'm then going to show you images that were taken 7 months later, when the patient felt a lump in her breast, in her left breast, and was shown as a mass with indistinct margins that had increased in size in the interval since the prior study. Ultrasound was also shown, as you will see. There was also a second mass found posterior to the index lesion and was seen both on mammography and ultrasound. Both of these subsequent lesions were biopsied under ultrasound guidance, and both lesions yielded invasive duct carcinoma grade 3. So let's look at the initial mammographic and ultrasound studies and then the studies that were taken 7 months later. So on this slide, you will see in the superior aspect of the MLO view a long red arrow, which was actually a false positive CAD mark. Where the shorter arrows are noted, these were the small, very tiny lesion, 5 millimeters, with CAD marks also identified. The ultrasound at this time was an anechoic mass, but not completely circumscribed, but nonetheless was diagnosed as a cyst. Next, I'm going to show you the mammogram that was taken 7 months later. And here you can see the mass is much significantly larger, ill-defined, and the red arrow points to the tiny mass right next to the pectoral muscle, which was a new finding with a new small mass. And both of these lesions were seen on ultrasound, which is the next slide. Ultrasound on the left, you will see that there is a tiny mass, which is the satellite lesion that we saw on the mammogram, about 8 millimeters in size, and on the right, larger lesion, which has increased in size since the prior study. So we have a small lesion that has gotten bigger within 7 months, indicating rapid growth. Now let's look at an interesting case. I'm going to start out by looking at the MIP image, which is in the upper corner here. And the main finding is the fact that we have an abnormal mass present in the left breast, centrally located, a little bit medial, and there's a second mass posterior to this finding, so we're going to need to look at that a little more closely. Let's look at the T2 weighted imaging, which we have here, and we can look at the non-fat suppressed T2 weighted image, and let's look at the finding that we saw on the MIP image. And if we look carefully here, in the center of the mass, we can see high signal. And we can also look at the posterior mass as well. A little bit of high signal in it also, but look at the pectoral muscle. We can see some fluid in the pectoral muscle. So this is actually high signal within the mass, and it can be seen with edema and with very highly aggressive lesions. We can look at this mass also in the sagittal plane. Let's take a look at that on the T2 weighted. And here also, if we go full screen, we can see high signal within the mass, and we can also see high signal in the pectoral muscle. Let's move on then to the post-contrast series. And we'll leave the T2 weighted image up in the corner here. And here we can see enhancement of the mass that we saw was evident on the pre-contrast study. Let's go full screen on this axial lesion. And we scroll through it, we can see this sort of lobulated, partly circumscribed index lesion with a second smaller mass located posteriorly to it. And we're going to move forward, looking at the pectoral muscle, and then let's go back up through the image again, through the mass again, looking for any abnormal findings. And here we see enhancement within the pectoral muscle itself, which indicates pectoralis muscle involvement. And I think if we go a little further, here we can see it here, we might be able to see another area of enhancement right here. So there's two areas which show significant pectoralis muscle enhancement. Interesting finding. Let's look at the subtraction images now. And we can scroll through again and see the subtraction imaging. So let's segment. Let's just look at the kinetic overlay for a minute, just to take a look at the kinetic map. And we can see here there's a lot of washout, plateau, and persistent enhancement throughout, and also some enhancement within the satellite lesion. And then, so we can take that off. Now let's segment our index lesion. And we're going to just go through it a little. Looking at the segmentation now, analyzing the lesion. And here we can see the segmented lesion. We can see the most enhancing curve and the average enhancing curve. And we can see the volume, effective diameter, and surface areas that have been automated and shown here. And then the QuantX score, we can note, is 71, which is well in the malignant domain. So in summary, we have a very aggressive lesion, very aggressive invasive duct carcinoma, and we have a satellite lesion, and we also have enhancement within the pectoralis muscle, which means that we have invasion of the pectoralis muscle, which is an important clinical finding. The final pathology yielded invasive duct carcinoma grade 3, and again a triple negative study, ER/PR negative, HER2 negative, and the Ki-67 was 80%, which was really significant for an aggressive lesion. The sentinel nodes were sampled and were negative for carcinoma. Another interesting part of this case is the fact that we had pectoral muscle involvement, and it was seen in two areas on the MRI. It's important to note that pectoralis muscle involvement may be seen as muscle enhancement with obliteration of the fat plane between the tumor and the muscle at MR imaging. So we may see obliteration of the fat plane as we're looking at the pectoralis muscle, but we need to have actual enhancement of the muscle itself in order to have a diagnosis of pectoral muscle involvement. So we need enhancement within the muscle itself. And although pectoralis muscle involvement alone does not change the clinical breast cancer stage, it is important to include this information in the radiology report because it will necessitate alteration of the surgical management, and some surgical excision of the muscle enhancement may be necessary. So this is important secondary information with regard to this very highly aggressive lesion. Indication. QuantX is indicated for the assessment and characterization of breast abnormalities from MRI data in patients presenting for high-risk screening, diagnostic imaging workup, or evaluation of extent of known disease. QuantX is not intended for primary interpretation of digital mammography images. QuantX is not intended for primary interpretation of digital mammography images. Labeling also provides information to users about potential limitation of the device related to specific subpopulations for use by licensed healthcare professionals only.